Thank you so much for the kind invitation, Dr. Khalid Al Habib, and I'm so pleased to be part of this virtual research academy. And you have kindly asked me to talk about healthcare knowledge production and the unmet needs, opportunities, and challenges, and more so likely you are expecting me to talk about that in our space of the region of Middle East and Africa, because you know how much I'm interested in this region. I am Fayez Zanad. I am Tunisian, born Tunisian, and I have been working more than 40 years in France in the University of Lorraine. I've been directing the Clinical Research Institute in INSERM, and have been mainly involved in clinical trials. I have a PhD in clinical pharmacology and an MD cardiologist, but because of this mix of clinical pharmacology and cardiology, my main interest was clinical research and mainly with drug therapy and clinical trials. So healthcare knowledge production and more so in the clinical side, because I'm not going to be mentioning any basic science here, because although I have done quite a bit of basic science, I would like really to focus on clinical research. There are different dimensions, and the main objective are with epidemiology to describe diseases, to describe healthcare system, and then to generate evidence in order to base the new therapies on the strongest possible evidence. Then using clinical data, you can also try to understand the disease, and actually it may be with the modern tools much more powerful than basic science in dissecting the pathophysiology of diseases in the setting of clinical patients. And then, of course, anything you are doing is, by the end of the day, hopefully going to benefit to the patient. And therefore, any clinical research should aim to change practice, to change our daily practice and our way to treat patients. And you will see that this is not straightforward. It's not because you provide the evidence that is going to be immediately changing practice. We need to get into interest into implementation research. This means finding how our evidence can translate to the daily practice. And this inevitably will also lead on clinical research and knowledge production about healthcare systems. And of course, we are all working for the future. And I will tell you a few words about the anticipation in the future, and more so, how all this applies in our region of Middle East and Africa. So first, generating evidence from randomized clinical trials. This is the highest level of evidence. I just would like you to take an example in heart failure. And on the left-hand side, you have moderate to severe heart failure. On the right-hand side, mild to moderate heart failure. And this is the accumulation of heart failure with reduced ejection fraction. The evidence started early in the 90s with the RALS trial, which I was co-PI of, and up to recently, and I should add another bar here, which is sacubitril valsartan and SGLT2 inhibitors. But just before we got there, you can see that mortality went down in the severe heart failure from 27% to 12%. 63-fold decline in mortality in HFrEF. Exactly same trend in mild to moderate, getting from 15 down to 6. And this is thanks to the accumulation of the many trials. I've been very privileged being PI or co-PI of many of these trials, certainly of mineral receptor antagonists, and the first ever mortality trial with beta blockers, CBIS. Now, this has led the path to many more HFrEF trials, and this is the latest comer, and this is SGLT2 inhibitors. And I have meta-analyzed the trial with Emperor reduced, which I was co-PI of, and DAPA-HF with dapagliflozin. And you can see exactly superimposable results and a very important and welcome addition in the armamentarium of treatment of heart failure with reduced ejection fraction, beneficial on the heart and the kidney. And therefore, we came to erect these five pillars, including loop diuretics and decongestion therapy, at the basis of HFrEF therapy and the basis of the modern guidelines. And you can see indeed the latest European Society of Guidelines is built on these four major classes, actually five, with sacubitril valsartan being as a substitution to RAS inhibitors. So the point I would like to make here is that compared to any other guideline, whether in cardiology and certainly in interventional cardiology, for example, or outside cardiology, heart failure with reduced ejection fraction guidelines are 100% evidence-based, 100% evidence-based. When you get to interventional cardiology, which is very popular, only 15 to 30% of the guidelines of level 1A are evidence-based. And therefore, you can see that there is no pain, no gain. If you give yourself the pain of going through all these trials, strong, large, powered, randomized, robust, you can get to the best possible evidence and the highest level of recommendation. And therefore, you can be very confident in the medication we are using in HFrEF, for example. So knowledge production is extremely important when it goes through the highest level of evidence generation, which is trials, because it's likely, and we'll see later how this translates into daily practice, but at least it gives you the very strong basis for treating and changing practice. Now, if we use this medication together, and we have done this simulation using evidence from all these trials, you can see together an optimal dose. You can see that we can bring down all-cause patients over 2 years in order to save one life. This is also the strongest evidence and the largest. You compare this to any other discipline, you will see that we have done the hard job showing all this medication accumulating benefit. And if we look at this data in a different way, and this is another paper we produced from the different heart failure trialists, this is translating the benefit of accumulating benefit from all these medication taken together an optimal dose. If you start all this medication in a patient age 55 years, you will have this 6 years of prolongation of life, gaining 6 years. This is not marginal. This is exceptional. And I would like really you to be proud of this evidence we have come up with. And you can see on the right-hand side, if you start the medication at 65 years, a little later, which is more frequent in our HFrEF patient, you have still a very robust 4.4 years prolongation of life. Exceptional benefit. And this is based on healthcare knowledge production and the highest way to produce evidence, which is clinical trials, randomized clinical trials. I still would like to focus my talk on randomized clinical trial. I could have talked about epidemiology, which is fine into describing, but you cannot provide any evidence, and certainly no causality from epidemiology observational study. You need this observational study in order to test whether the evidence is being applied, to test whether the evidence is being reproduced in real world, but generating evidence is randomized clinical trials. Now, this is the bright side of what we have done over the last 20, 30 years, but there is the dark side, because we didn't succeed all the time. We have failed so many times and so often. And by the way, the clinical research experience, clinical trialist experience is the most humbling experience I have went through, because we had so many great hypotheses in acute heart failure. And you can see this, whether decongestion, inotrope, vasodilator, neurohormonal modulation, and anticoagulation, all these hypotheses as potentially life-saving therapies in acute heart failure has been proven to be wrong. So it is humbling, but at the same time, it does help you understand the diseases. And therefore, acute heart failure is not simply congestion. It's not simply a neurohormonal or inflammatory storm. It's not simply the heart which is fatigued, and it's not only hemodynamic and not only coagulation. There must be multiple other mechanisms which we still have to tackle, because so far we have only neutral or negative trials. So we have learned something on acute heart failure, which is not simply, chronic heart failure acutization with some same pathophysiology that chronic, yet only acute. And we still need to understand better this disease. Well, the other important, indeed, task of clinical research is understanding the disease. So you see, from randomized clinical trial, we can really understand from our successes and failures the pathophysiology and mechanism of action of medications. Now, we can go further from using data from trials, and any modern randomized clinical trials should contain biomarkers and biosamples, because this is the best way in clinical research to do pathophysiological research. This complex slide is what we call a network analysis. We have measured hundreds of biomarkers using proteomic screens in patients at risk to develop heart failure, whether they have diabetes, hypertension, ischemic heart disease, they didn't have heart failure. And we monitored these patients over a long period. We have worked on our own cohort. This is a European funded program. We have worked with Framingham, we have worked with ARIC and many other important cohorts. And it turns out that patients who progress to heart failure express these very important clusters of mechanisms, which is many proteins indicative of extracellular matrix remodeling and angiogenesis. This is typically fibrosis, which is one of our favorite mechanisms. You can see on the top left, blood pressure regulation and certainly the renin-angiotensin system. And on the bottom, a very large cluster of many proteins, which are indicative of the inflammation and apoptosis. So you can see these are likely to be very important mechanisms having patient progress from at risk to develop overt heart failure. And therefore, these may be biotargets. If we develop antifibrotic medication, anti-inflammatory medication, and we know already that medication will mitigate blood pressure and certainly renin-angiotensin system, can be biotarget, which may delay onset of heart failure and slow the progression to heart failure. Now, this is indeed the best scenario, and I have coordinated two mega programs with European funded. One is called HOMAGE. Typically, what this means is heart omics and aging. We use multi-omic approach in understanding the development of heart failure in the elderly, and FibroTarget, which is dissecting the molecular mechanisms behind the fibrosis, pretending to the progression to heart failure and progression of heart failure. The general conceptual framework is, yes?
Yes, sorry to interrupt you for a second. Could you please, may I ask you to stop sharing the video? So your because your sound is lagging behind, so the streaming will become more faster.
Here it is.
Yes,
I'm
good.
done.
Thanks a lot.
So thank you. So the ideal framework is indeed, whenever you understand the mechanism of action, you can identify these biotargets, and these biotargets are measurable as biomarkers. This is the ideal setting. And therefore, you can select patients who express these molecular mechanisms, just measuring the biomarker in the blood. And then you can identify patients who are expressing these biotargets and therefore most likely to benefit from a therapy directed to these biotargets. And this is exactly what is precision medicine about. Let me give you one example. In 2000, this is 20 years ago, when we have done the RALS trial, which was spironolactone compared to placebo in severe heart failure, mortality was taken down 30% thanks to the use of spironolactone in these patients. Now, we have measured biomarkers, and we know that anti-aldosterone therapy is a very potent antifibrotic therapy. So we've measured collagen biomarkers, fibrosis biomarkers, and on the left-hand side, you can see patients who are all having severe heart failure. If you divide them according to the median of the level of fibrosis, patients who have low fibrosis biomarker didn't change whether on Spiro or on placebo. On the top left, you can see patients who have fibrosis above median. And you can see, of course, placebo is ineffective, but then you have a 20% decline in fibrotic biomarkers with spironolactone. This shows that indeed, in the clinical setting, mineral-coated receptor antagonist has a very potent antifibrotic therapy, which can be traced using biomarkers. Now, the most important part of the story is on the right-hand side. This is the survival benefit of therapy. On the top, you can see the overall survival from this trial is 30% decrease in mortality thanks to the use of spironolactone. Now, if you split patient according to their biomarker profile, anything in blue are patients who are not fibrotic from the pro-collagen type 1 or type 3 measurements. Anything in red are patients above median. These are very fibrotic patients. And you can see in the non-fibrotic patient, there is hardly any benefit. Spironolactone doesn't work. But in the patient who have high fibrotic profile, benefit was almost 50% decline in mortality. And therefore, the idea came that why we shouldn't screen patients according to their fibrotic profile and then treat them according to this by only expose these patients to therapy and not necessarily expose patients unnecessarily to MRI therapy if they don't have fibrosis. This is indeed the fibrotic profiling, bioprofiling, using biomarkers, which may be selecting patients who may benefit from therapy. It is precisely this hypothesis that we have tested in the HOMAR trial, which is heart omics and aging. And we have selected patients at risk of developing heart failure, not heart failure patient at risk. This is prevention of heart failure. And we exposed them to spironolactone or placebo. And we only measured collagen biomarkers. This paper is published in European Heart Journal. And indeed, starting from month 1, I'm not going to be showing the results on the collagen biomarkers, but indeed, at 1 month, we have a very profound antifibrotic effect, a very profound decrease in NT-proBNP, and over the follow-up in echocardiography, there is a very potent favorable effect on remodeling in patients at risk of heart failure. But what is important is how did this work? And using proteomics, we could indeed identify the mechanism for the first time ever in humans. Every mechanism which had been described only in animals with spironolactone and MRA, we could reproduce using proteomic biomarkers profiling. And you can see patients who benefited from this therapy had a very potent effect on extracellular matrix, as you can see on the left-hand side. But there are many more mechanisms. Certainly, the size of this rectangle, which is blue on the left, is the largest contributing effect, which is antifibrotic therapy. But there are many mechanisms, certainly remodeling, angiogenesis, inflammation, adipokines, and this has all been demonstrated in animals. But in this JACC paper, for the first time ever, we could reproduce this mechanistic profiling of patients responding to MRA therapy. So this is another way describing the disease and understanding how drugs work. Now, I'd like to shift, and I'm sorry, it is inevitably very short, so I'm really having a very quick overview. And I would like to progress to the third segment of my talk, which is implementation science. And these are two important people who did say the same thing centuries apart. the most important thing in discovery is not the discovery itself, is when people benefit from the discoveries. And this is what we call implementation. So anything I have shown you, which is described in the mechanisms of the disease, providing evidence is fine. And I had fun and it's really great science. But until this comes to your patient and make your patient benefit from this, it's really not worthwhile. So, and indeed we have an issue. In HFrEF, this is among multiple studies you have seen that everything we are doing is not getting to the patients. And there are challenges in having patients in all therapies effective in heart failure because of side effects, but mostly about the concern about adverse events. This is what we call medical inertia. Doctors are very much concerned about hypotension, worsened renal function, hyperkalemia. But we know that despite this adverse event, the net benefit of this therapy is that these are life-saving, despite all the side effects. And therefore, we need to do the hard job, implementing therapy and up-titrating medication until we get the safest possible tolerable doses. Now, how we can do so? Well, publishing guidelines is fine, but this is not enough. Publishing guidelines is only, structuring the evidence and learning and teaching people about this evidence. We need to get them to apply this evidence. And this is what we call implementation science strategy trials. And I would like just to give you two examples. One of them is disease management programs. Every single cancer patient has a chance to meet an oncologist or to be managed by an oncology specialist, not heart failure patients. Heart failure patients most of the time are dealt with general physicians. We need to help general physicians with heart failure units, heart failure clinics, heart failure disease management program. Heart failure is a deadly, costly disease which prognosis equals the prognosis of multiple cancers. So this is disease management program. And I will show you one example. And the other built in the disease management program is exploration of remote monitoring. And I'm only taking one example from our own research. So disease management program, the best evidence, and that disease management program in heart failure has got the strength of recommendation 1 and the strength of evidence 1A. I mean, if your healthcare system doesn't have a heart failure disease management program, and basically best is based on home nurse, heart failure nurse, then you are not applying the guidelines. You may be applying the 1A beta blockers, MRA, SGLT2 inhibitors, but another 1A recommendation is having your patient cared for by a disease management program. This is what we have applied in our place in Lorraine, the northeast of France, 1.5 million inhabitants. And we have started what we call ICALOR, Insuffisance Cardiaque en Lorraine. This is a home nurse-led community-based program covering 1.5 million adults, 29 healthcare facilities, and which enrolled 3,000 patients. Compared to the red line, which is the inexorable increase in heart failure hospitalization in all of France. And this is similar in all countries. There is an inexorable increase in heart failure admissions. Now, we have exactly the same thing occurring from 2000 to 2005. And in 2006, we have applied, and you can see it here on the blue line, this system. And we have flattened the progression of heart failure hospitalization. This corresponds to a benefit of 40% prevention of hospitalization. And we have done the mortality study, which showed that actually we prevented 35% of all-cause death, which is extremely coherent and consistent with the best possible implementation of guidelines. We have published all these in multiple papers, and we have shown that this is very cost effective. Implementing evidence-based therapy with the use of home nurse-led community-based program may be very cost effective. Basically, when the community give me €1, I'm giving them back €5. Extremely cost effective because you are saving life and keeping patient home. So these are the type of implementation program. You need to get to your director of hospital or healthcare system and finding out whether you can use this type of program in order to enable the use of a very strongly recommended medication in heart failure. Some other way to help with the implementation of this therapy is remote monitoring. And I'm sure you are familiar with the CardioMEMS, pulmonary pressure monitoring. I'm not going to be dealing with this, but this is a very efficient way whereby patients are having their pulmonary pressure monitored, and doctors, depending on the pulmonary pressure, they can intensify therapy. Now we have come up with another model, because the main deterrent and limitation of use of therapy in heart failure is worsened renal function and hyperkalemia. So we got with this system we called Cardo Renal. This is a startup I'm developing with my deputy nephrologist, Dr. Arsignol, with a droplet of blood where you may measure hemoglobin, which is a great surrogate of hemoconcentration and hemodilution. This means congestion and decongestion. And we can measure potassium and creatinine. We are in a clinical research development and testing this conceptual framework. Then if you have the patient self-monitor their state of congestion, their state of renal function, and their potassium, and have the information got into a secured loop to the doctors, and this is embedded in an algorithm which will instruct the doctor what to do with the patient treatment optimization, you may end up by the best possible optimization and improving survival. This is undergoing clinical research at this time. Now, I would like to take this remaining minutes to discuss the future, how my experience in clinical research may help, and may help more so develop clinical research and healthcare knowledge production in our space, Middle East and North Africa. Well, this is a quick description, according to WHO, of the state of cardiovascular diseases in the region. I'm not teaching you anything. You know that cardiovascular disease is still #1 cause of death in our place. That the main reason of this is the sedentary lifestyle and common risk factor, obesity, hypertension, diabetes, hypercholesteremia, and physical inactivity, and smoking, which is rising. And therefore, one may think twice whether the Ministry of Health in our countries have a better job in investing in high-tech, lucrative, and cost, curative interventional cardiology, very sophisticated surgery, cardiac transplant. This is very fine, but it will hardly be effective on the healthcare system if this is not accompanied by preventive healthcare and investing heavily in prevention, which is a huge gap all over the world in general, and more so in our region. Prevention of smoking, of sedentary life, of hypertension, of diabetes. And I know how much diabetes and obesity are really a rising epidemic in our place. And therefore, in order to implement prevention strategy, we need to describe better the state of health of our citizens. And I've looked on what is available. And this paper is actually a systemic review of most of what is available in the prevention cardiovascular in our region. And you can see this has searched through 3,000 published papers, only to get down to 32, which are studies with good quality, good quality. And this is the emphasis of this slide. We have an issue of producing data quality, which may safely get us to build healthcare policy. Changing healthcare policy based on shaky data, on poor data, is really, really hazardous. So number one objective is we need to improve data collection and data quality collection. Now, there is a whole lot of clinical studies. On the left-hand side is any study in our region. And you can see most of these are concentrated in Turkey, Egypt, and South Africa. And you can see that in Africa, which accounts for almost 16% of world population, only 3.3% of clinical study worldwide are conducted in this region. Middle East is doing a better job. Middle East is less populated, 6% of world population, and in Middle East there is 3% of clinical studies which are conducted in the Middle East, and these are mainly in Saudi Arabia, by the way. Now, if you get on the right-hand side to cardiovascular now, on the left is all clinical study, all disciplines and epidemiology, trials, everything, right? You can see the numbers are very high. On the right-hand side, the numbers are very small, and this is only cardiovascular on the one hand and only clinical trials on the other hand. And you can see the record is even lower. Only 2% of cardiovascular clinical trials is conducted in Africa, which accounts for 16% of the population. The record is much nicer in Middle East. 4% of cardiovascular clinical trials are conducted in Middle East, and this is 6% of world population. We are close to balance. That's good. We need to have Africa match the experience in the Middle East and improve the experience in the Middle East. Now, this is a typical slide number 2 of any major trial shown in late breakers. I have shown the same thing with Emperor. This is DAPA-HF SGLT2 inhibitor. And you can see that no African, no Middle Eastern country in this map which have enrolled patients in an SGLT2 inhibitor trial. So how we can implement the result of SGLT2 inhibitors if we haven't really enrolled any patient in trials which are leading to the evidence of use of SGLT2 inhibitors in HFrEF? We need to do the job and have our sites, our colleagues get to do the job and enroll patients in these trials. The main reason is the development of capacity of research, and certainly Africa is really, really lagging behind. There is a lack of robust international standards and regulatory framework, and there is uncertain public confidence and poor awareness of the other importance and the objectives of clinical research. And you can see that in the COVID crisis, Africa and Middle East were low as compared to the Western world in generating the evidence for vaccine, for example. So this applies in cardiovascular as well. And we need to do the job in order to prepare our region to be a producer of healthcare knowledge and rather simply a consumer of healthcare knowledge. Now, if you go to the Global Clinical Trials publication this time, right? And we have ranked them by first author. You can see that Africa, Middle East have very low record of first authors of publication of clinical trials overall. Yet we have great university, we have great scientists, but we don't have the infrastructures. So how can progress from there? This is a further evidence of the huge dominance of Western Europe and United States when it comes to leadership in trials. This is a paper we have published in European Heart Journal. And you can see on the right-hand side, most of the papers produced in heart failure trials are led by Western Europe or United States. There is less than 10% of trial leaders are from our space, and less of these will have trial collaboration. And the discrepancy is mostly visible in industry trials. So we need to do the job and take the leadership of trials performed in our space. And this is the ROW, what the United States call rest of the world, which, by the way, is not rest of the world, but is most of the world, given the heavily densely population in these spaces outside Western Europe and outside the United States. Now, there are promising regulatory initiatives in few countries in the region, and certainly Saudi Arabia, Egypt are part of them. And progress is being made toward higher standards of human subject protection, adequate functioning of ethics review systems, and streamlined authorization timelines. And this is a slide from Saudi Arabia showing the progress done over the last 10 years with many important reforms of the regulatory system and the guidances and good clinical practice, including collecting samples and participating in important biosample pools and biomarker research. So this is a typical great example to follow in other regions. Because doing clinical trials not only produces science and knowledge, but it also produces business. I'm taking here the example of Poland, who has invested very heavily to teach their nurses, their doctors, their hospital, to capture the largest possible number of clinical trials. And therefore, they are accessing now to the 9th largest global market of clinical trials, Poland. They're including the huge number of patient clinical trials. And you can see this has amounted to 1% of global domestic products is coming from participating clinical trials. So it produces money, it produces business, because big pharma are desperately finding sites with good quality who are able to enroll a large number of patients, because time is money. And therefore, engaging in clinical research and clinical trials not only helps producing knowledge, but it does produce wealth. Now, we have assembled a large group of colleagues in a meeting I have been organized, which is called CVCT, Cardiovascular Clinical Trials, and we have done this meeting in Middle East. And we have assembled, and you can see the name of authors here, a number of academics, but also regulators in the space in Africa and Middle East. And this is the meeting. We have been putting the CVCT Middle East on pause because of COVID, and I hopefully will resume this meeting soon. And we have come up with this roadmap to help the healthcare system in the region promote clinical research and get from this sweet spot, which is on the left. With this roadmap for clinical research in the region, we have identified a number of initiatives. I don't have time to go through them all, but mainly, again, there are in this paper, which has been published in Global Health Research, and I'm happy to provide. And I would like just to emphasize on one important training objective. The main gap in our healthcare production is training of clinical researcher, clinical scientists, healthcare practitioners, whether they are doctors or nurses, to generate evidence and to do clinical research. Training is essential. And we have put together this cardiovascular clinical trials program, but we have specifically in the global meeting of cardiovascular, which is now taking place in Washington, and I'm chairing and organizing this meeting, I have managed to have a large number of fellowships directed to academics who are willing to be trained in clinical research. And this is a discipline as much as interventional cardiology, as much as heart failure specialists, as much as echocardiography, and as much as heart surgery. Cardiovascular clinical research is a discipline, and we can take leadership, and we need to train the future leaders. And basically, this program is enabling young trialists to get into steering committees of mega trials and become full members, and therefore to learn the job of steering, conducting trials, and producing evidence. And we are enjoying this program with the help of a number of companies, but also from the NIH. And we would like really you to get to the website and apply and have your young people apply. And therefore, I would like to mention a number of initiatives, which is the career escalator, having young people have a very privileged time to one-to-one meeting with mentors, and many other grants training young people, and very much emphasis on diversity. We are discriminating positively in order to help women and help people from different origin and different region with this. So I would like then to end this talk inviting all of you to log into this platform, and you have the email address here, from the 2nd to the 5th of December, now almost in a month, and you will learn much more than anything I could tell you today in my presentation. You have the best possible people worldwide assembling, and this is almost 380 speakers coming from all spaces, from academy, from regulator, the Food and Drug Administration, the European Medical Agency, the Japan PMDA. Major journal editors are there, patients are being represented, and industry, research and development. And this is for free. Any one of you can log in, enjoy almost 40 sessions, screening across every modern knowledge about heart failure, atherosclerosis, surgery, thrombosis, all disciplines of cardiology. So welcome on board of CVCT. And I hope that I have been only teasing you with my talk into engaging in knowledge production, healthcare knowledge production, and more so in cardiovascular knowledge production, and stop in our region being only consumers. We have everything, and we have all the capacity in our region to join the global effort of knowledge production, especially in healthcare and more so in cardiovascular. Thank you so much for your attention, and I would love, answering questions, if any.
Thank you very much, Professor Zanad. As expected and as usual, very stellar and very intriguing and inspiring talk. I have attended several CVCT meetings in Paris and Abu Dhabi, and I can testify that it's a very unique meeting, and it's not one of these usual conferences that you attend and you barely remember that you benefited much. I have to tell you as well that I rarely hold my phone and take pictures during virtual meetings. I have taken at least 10 pictures from your slides, if you allow me, so I can go back and try to get the references and send them to my research network and my scientific network, particularly the CVCT announcements. So I would really urge people who attended this, and we have almost over 170 attendees so far in this meeting. We have here a question from Dr. Fakhr Al-Ayubi. How do you help women? How about the pharmacist's role in this project? And you have a background in pharmacy as well, so you're a double-edged kind of a clinician and pharmacy background as well. So you kind of have bias toward both.
Oh, yes, thank you. Pharmacists are fully part of the game. I mean, there are as much clinical scientists and clinical researchers like doctors. So we have pharmacists in almost all our studies, and but they need, as much as doctors, to be specifically trained in clinical research. Pharmacy is the basics of any drug trial. Of course, even with devices, we need pharmacists as well, because they know best about drug and device delivery. So anything I've said applies actually to pharmacists, and they are very much welcome to be part of the clinical trial effort. Women, well, we mean it really, because you know that there are so many initiatives in order to help women leadership. Anything I've shown you with the lack of leadership from clinical trial first author in the region is even more desperate when it comes to clinical trial leadership among women. And therefore, we need to positively help this and fill the gap. And in CVCT meetings, we have the highest possible representation of women among faculty members. We are partnering with an initiative in the United States called Women as One. So any lady listening to us can look at the website, Women as One. And Women as One is promoting women leadership in clinical science and clinical trials. And anything we are doing to women actually is not specifically women, it's only promoting diversity. And diversity among regions, diversity among ethnic background, and diversity among gender. And this is a very important high on the agenda from multiple countries. So I really would like you to look into the CVCT website and to look to all the initiatives. We had one full session explaining how we can fill the gap of diversity and promote participation of minorities who are not being involved in this effort of clinical trials.
Great, thanks a lot. One of the issues, as you pointed very elegantly, and you have been part of the of both parts of the world, and the Western part of the world, and leading major research, and actually being part of trials that have changed our practice on daily basis. And you have been also back to your home country, Tunisia. And I remember that you told me once that you've been a consultant as well to the Minister of Health in Tunisia. So I've been part of the system, and you have seen, you're not somebody who just in the Western world, and you also went back home and you have seen both sides of the coin. Where to start? I mean, if you, as you pointed already, there have been many lacking infrastructure that are important for research. For example, in our part of the world, Saudi Arabia, for example, just established a Saudi NIH, which will be very helpful in supporting research and so on. How about other countries that do not have this capacity? What would be your, let me say, very few essential steps that we can apply at an individual level, at a hospital level, and at a Ministry of Health and a population level? Do we need more trials to get involved in randomized trials, or do we need to start with the basics? How do we start?
Well, it's really a complex question, and I have given it quite a bit of thought, indeed, because I've been asked to help in Tunisia, but also in Egypt, in other countries, on how to get to fill this gap that I have emphasized today. To make a long story short, then, having only selecting one or two items, simple items. One is training. Training. We don't have in the curriculum of the medical university in our region a specific curriculum of training about clinical research and clinical trials and evidence generation. This is an anomaly. We have much training of cellular biology, biochemistry, mathematics, whatever, but not a very important discipline, which is clinical research. And embedding clinical research in daily practice. Daily practice produces knowledge. If you capture your daily practice information in healthcare disease management programs. And certainly, if you have an electronic health record, this is reform number 2. I have been advocating 3 reforms. One is education and embedding curriculum of clinical research training in universities. Second is digital health, getting to have patients with electronic health records. In majority of our sites and hospital, you can hardly have a paper record. Let it be electronic health record. Clinical research is basically good quality and data sharing. And digital health and have an electronic health record help you very much improve data collection and quality data collection. So this is the second very important reform. And the third is, of course, a dream. No one can really have it all on his own, and no country can do it on its own. Europe has united and have done the European Medical Agency. Asia Pacific has done so. The United States, a huge country, have their Food and Drug Administration. We need to have an agency in our region, or maybe 2, Middle East or African or both, an agency which is filtering down the regulatory affairs and approval of medication. And therefore, this will become a strength, and every big pharma, every big funder of research will get to our region. But if we are competing, or maybe not even competing, going to the market on our own, every one of us individually, we will not get there. So 3 advice: training, digitalization of healthcare, and getting it to be done together.
Well said. Yeah, unfortunately, Professor Zanat, the research is in many parts of our region is looked at as kind of only for the academics who would like to get promotions. And unfortunately, even when they get promoted to full professors, they stopped doing research. So it's not even for the sake of improving, I mean, partly improving the health of people and humanity, but this intention for improving health of humanity stops once people get promoted. And I like your slide about saying that, I mean, you have to understand why we're doing research. I get approached every now and then by people who would like to get to do research and so on. And it's very obvious that they are doing it just for their promotion and doing any kind of research so they get up in the ladder, rather than really trying to say why we're doing this and is that really going to benefit humanity. One last or maybe 1 or 2 take comment questions. Dr. Shukri Saif from the Eastern Province saying, one challenge that we have faced is insurance. Insurance to cover potential harm to subjects or patients in investigator-initiated studies. Any advice or ideas to overcome this?
Yeah, well, this has been dealt with very appropriately with insurance companies. Of course, they have an insurance policy which needs to cover the risks related to the participation in clinical trials. But insurance is also very heavily, capitalizing on healthcare system. This is a political decision. If the most of hospitals have their own coverage of insurance, this may take care of the risk also related to clinical trial. And of course, there is a matter of education. The risk of doing harm to patients is much higher in patients not participating in a trial than in patients participating in a trial. Patients participating in the trial, if any, fare much better. They have fewer side effects because they have full, better monitoring and protocols, and therefore this is again about education. And the hospitals
negotiation with the insurance.
Beg your pardon?
It's a matter of negotiation with the insurance and trying to put the point that it's, if anything, it's actually more well-controlled environment. That's, if anything, is less
absolutely, but more so with the hospitals and healthcare facilities and clinics. Let them accept to cover the insurance of your insurance being an investigator. because they will decrease the number ultimately of side effects or hazards in their patient population, not only indirectly because patients who are in trials, they will have less risk, but because you and me and doctors who have been learning the clinical trials, they are much better doctors. And therefore the doctors in their hospital will be much better doctors, and therefore the risk is much lower. So this has been proven. There are multiple publications in this, and actually most healthcare facilities now do cover the risk related to clinical research, because they know by the end of the day they will be doing better healthcare.
Excellent. Yeah, I can testify to this. Many people, even being enrolled in registries, let alone trials, they tell us once doctors and emergency doctors, for example, heard that you're doing an acute syndrome registry, everybody is on the top of his toes, and now they're trying to pay attention to the benchmarks and the beta blockers. Did we give the this drug on time and so on? So just doing an observational study by itself in a hospital, that by itself, you can notice the whole culture in the hospital changes and affecting multiple departments, which is basically goes back to the what we observe as humans. Once we get observed, we kind of tend to behave more, I guess, and be more attentive.
You are really hitting the nail once you get to be observed, and this is the major limitation to get to electronic health records. Most of our colleagues hate getting in electronic health records because they know if they share their data, they are going to be observed. Because there is electronic health records have value only if you merge the data from different hospitals, different clinics, and compare to each them. This can be done very safely, very confidentially, and we need to reassure our colleagues that this is not going to be having been pointed, but only improving their quality, because if they improve the data capture in electronic health record, they also will become a better doctors. So it's really a virtuous circle participating in clinical research in general.
May I ask you last question before we finish? The electronic medical records in our region, at least, you kind of tend to just write notes. So it's kind of impossible to come out with any data, let alone merging data from other hospitals. Is it different in France? I mean, do you actually have specific points that you have to fill data?
Oh, you are really hitting the nail here, because we have exactly the same issues worldwide. And in France, it has taken billions before building a national electronic health records. There have been a total mess in order to get there. There are many factors which are limiting progress to digital health. Of health in Tunisia, I just want to find one single deterrent, which is willingness to share. If you have the information in our culture, we have the impression that we are holding power. Information is power. Sharing information is sharing power. And therefore, it's a matter of mentality. Shifting this from fearing sharing and losing power versus gaining power, because we need to show that sharing information is gaining power, not losing power. But the first reflex is really this limitation, and again, matter of education, showing virtuous example where by merging databases produces more knowledge and help you to better practice.
Well, there's nothing better than what you just mentioned to close this session. Sharing data and sharing information is sharing power. I'll put that in one of my slides in the future. Thank you very much, Professor Zanad. It has been very inspiring. I have to say that I have several slides to go over your presentation, to go back and retrieve some of and many of the data that you showed us, to learn from and go over many of the information. I hope that our attendees today, we over 170 attendees today from the region, really appreciated to take your time in a Sunday afternoon to share with us your great expertise and knowledge. I really urge the attendees to attend the CVCT meeting. It will be virtual, right?
It will be virtual again this year because of COVID, and therefore a great opportunity for anyone get there very easily.
It all in the conference, very successful. Really a great pleasure, and really looking forward to have you again.
A final word about sharing. I'm most pleased to share my slides with you and whoever is likely willing to have them. And on CVCT, we mean sharing as well. Every single presentation, and there will be load after the meeting. So this is sharing. We mean sharing.
Thank you. Thank you. Thanks a lot. And again, highly appreciated. And looking forward, and thank you for contributing to the first inaugural lecture and keynote speech for the Virtual Research Academy under the Saudi Heart Association. And really have been a great pleasure, Professor Zina.
Bye-bye. Thank you so much. Bye.
Bye.